If you're a healthcare practitioner that interprets blood chemistry tests for your patients, you're going to want to pay attention to this video, because in the next 10 minutes, I'm going to show you 3 powerful ways that you can improve your very next blood chemistry interpretation. Let's take a look. The 3 things you're going to learn are, number 1, the one change that's going to make every single blood chemistry interpretation that you do even more accurate than it is right now. Number 2, we're going to look at a blood chemistry marker that most people don't pay much attention to, but when you see what it indicates, you're going to wonder why it's not on some labs. And number 3, a simple calculation using metrics that are already on the blood chemistry that'll tell you more about your patient without additional expensive lab testing. Number 1, the one change that's going to make every interpretation more accurate. Before I say what that is, we have to agree that the laboratory reference range or reference interval is the most important part of a laboratory test. The reason why is because if something is inside or outside of that range is going to dictate diagnosis, treatment, intervention, whether somebody is healthy or somebody is not. There's no more important part of a lab than the laboratory reference interval. In fact, it's so important there are different initiatives around the world that are taking place where people are coming together trying to find a better, more optimal reference range for a number of biomarkers. That tells you how important it is. So, what is this one change that will make every interpretation more accurate? Evidence-based from the scientific literature optimal reference ranges. We're going to use albumin as an example to show you what I'm talking about here. So take a look at these numbers. Now this is in international units. If it's in the US, you can use that. But look at the low end of these albumin. 44, 36, 43, 40, 36, 35, and it could be 3.5, 3.4, 3.3, depending on the lab. But when you look at that, you have a low of 33, the 36, 43, all over the place. The upper ends isn't so great either. You have as high as 56, as low as 48. Now, these are different albumin reference ranges on different labs or from different initiatives around the world. This means that if your albumin was 38 or 3.8 and you went to one lab, you'd be normal, but you went to a different lab, then it's abnormal. That is not health. That is not helping or measuring accurately anything. The wrong reference interval, as you can tell, is going to misdiagnosis. You're going to give the wrong treatment or no treatment at all if you don't think it's out of the range. Incorrect information said to the patient. Maybe somebody's sick, or maybe they're told they're healthy when in fact their physiology is a little bit backwards. Increased healthcare costs, and so much more. This is a critically important aspect of blood chemistry. So let's take a closer look at some of the literature that might give us a better idea of what an optimal albumin reference range might be. Here's a paper. This looked at about 31,000 hospitalized patients, and what was found was that when albumin was a greater than 45 or 4.5 had the greatest chance of survival. Well, you might say, well, that's sick people in the hospital. What about healthier individuals? Well, stay tuned. In the Framingham Offspring study, 5,000 individuals, was found that mortality was lowest when their albumin was above 47 or 4.7. Now put these two together. Where would you want your albumin to be? 45, 47? Here is looking at serum albumin and cognitive impairment, almost 2,000 individuals over 65 years old. It was found that when albumin was lower than 44, that cognitive impairment went up. And then lastly, probably the best study of all, 1.7 million healthy people followed for 12 years, and what was found was that men, when their albumin was below 44, or women, when it was below 42, had an increased chance of all-cause mortality. Let me just stop right there. Based on these, where would you want your albumin to be? Above 44, above 45, 46? We saw, okay, very different than some of those ranges we saw on that initial page. Now, why would you want to pay attention to albumin? Well, it turns out that the lower the albumin, the greater the risk for diabetes, the greater the risk for coronary heart disease, the greater the risk for bone fractures, the greater the risk for inflamed fat, which you know is associated with a wide number of cardiometabolic disorders, as well as increased risk of mood disorders. We need to be paying attention to albumin, and we need to use a better reference range. Do we need to get angry at the fact that all these albumin reference ranges are all over the place, or can we simply use what's in the scientific literature suggesting what a better, healthier, more optimal reference range probably is? The reality is I've been spending a long time looking at the literature, looking for optimal reference ranges, and all these markers you see here, there is scientific literature suggesting a more optimal or more healthy reference range than what is provided on the lab. Number 2, a commonly misunderstood biomarker and what it really means when it's out of range. Now, the reality is we're using a lot of great markers, but the information about these markers is out of date. We're going to use GGT, or gamma-glutamyl transferase, as an example. Now, if you're conventionally trained as a medical doctor, physician's assistant, nurse practitioner, dietitian, then why is GGT sometimes high? You'll hear things like liver issues, biliary tract issues, alcoholism. So hepatitis, cirrhosis, pancreatitis, carcinoma, usually the liver, alcoholism, maybe smoking, congestive heart failure, biliary tract obstruction. Those are the things that we normally think about when GGT is high. And those are all very significant, serious conditions. But they're also, that information is outdated when you look at the scientific literature. More updated versions of why GGT is high normal, and there's a lot of literature on this, is it's a marker of oxidative stress, specifically of glutathione need, possibly in the liver, as well as environmental pollutant exposure. Now look at this. Many papers say that GGT, when in the high normal range, or within the physiologic range, which means within the laboratory range, is associated with all-cause mortality, a greater risk of things like diabetes, hypertension, arterial calcification, cancer, and is a better marker of other disease risk like CRP. It's a better marker for disease risk. That is far better, far cooler information. So let's look at some of these papers really quickly. This paper said, and the italicized is mine, is GGT, even at physiologic levels, was associated with increased risk of or all-cause mortality and cardiovascular mortality, looking at almost 600,000 people. Here's a paper that says, again, the italics are mine, increased serum GGT activity, even within the high normal values, inside the laboratory reference range, is associated with an increased risk of major vascular and non-vascular outcomes. Where would you want your GGT? Within the laboratory reference range? If it's high normal, there's still potential issues. GGT is an early predictive marker of atherosclerosis, heart failure, arterial stiffness and plaque, gestational diabetes, various liver diseases, including viral hepatitis, other infectious diseases, and several life-threatening cancers. Early predictive marker. It's a marker of glutathione depletion. It might reflect increased exposure to environmental pollutants and is a stronger predictor of disease than other symptoms and markers like CRP, A1C, and uric acid. Here's the traditional reference range. Well, it turns out if you're in the high normal range there, you're at an increased risk for a whole bunch of things, and therefore an optimal reference range, which is based on the scientific literature, which I'm not going to go into now in the interest of time, is better. Here's a couple proof of concepts. In this particular book, they covered a paper that looked at type 2 diabetics. They took their GGT levels. They gave them 1,800 milligrams of N-acetylcysteine a day for 12 weeks and found that GGT came down, which makes sense. GGT, N-acetylcysteine increases glutathione. Glutathione is related to GGT, as we just saw. Here's another one, that ubiquinol, or CoQ10, when given to subjects at 150 milligrams for only 30 days, also significantly decreased GGT activity, as well as the body making GGT. All right, so that was a commonly misunderstood biomarker, what it really means when it's out of range. You want GGT on your test. In addition to that, once again, there's a whole bunch of markers where we're using outdated information, and in the scientific literature, there's a whole bunch of new nutritional, functional, optimal information that we could be using to better evaluate our patients and our clients. Here's the last one, a simple calculation to identify important information about your patient without the expense of additional testing. The reality is there are a number of validated evidence-based calculations and ratios on a blood chemistry that often use the markers that are already on there that can tell us more information about our patients than is actually printed on the lab. And this allows us to read between the lines a little bit better. Now let's take a closer look at one of them. That's going to be viscosity. Viscosity makes sense. It's the thickness of blood and how easily blood can flow through the vessels. Now it turns out the thicker the blood, the more disease and dysfunction. If you don't believe me, take a look at the literature. There's a whole bunch on blood viscosity as preceding chronic disease. It's very interesting. Understand that you can't manage something if you don't measure it. If you are not evaluating viscosity in your patients and clients, you can't manage it. You can't do anything about it. So here's an evidence-based, validated calculation for viscosity. And notice all you need is hematocrit, total protein, and a calculator would probably be helpful. It's not a very difficult calculation to do. I'll show you an example. Let's say you have a hematocrit of 44 and a total protein of 70. You plug those in, you do into your calculator, you come up with 16.8. You can look at a evidence-based optimal reference range for viscosity, and you find that 16.8 looks good. It's within range, and viscosity is not a problem for this patient. If it's too high, then it might be something you might want to consider. Why? It turns out that viscosity is a better marker of dehydration than traditional dehydration markers. Blood viscosity is associated with a whole bunch of different cardiovascular issues like silent cerebral infarction, better than traditional conventional markers, by the way, things like hypertension and cholesterol. Viscosity is associated with more arterial stiffness in type 2 diabetics, as well as more arterial stiffness in people with fatty liver, as well as it's an increased risk of bone fractures and decreased bone density. And if you have higher viscosity or an increased risk, there's more association with gallstones. We need to be looking at viscosity. Here's a paper that actually suggests that blood viscosity precedes glucose dysregulation, that viscosity goes up first, and then you get abnormal glucose excursions. This final paper says that blood viscosity is so useful. It can add useful information about the diagnosis and treatment of various disorders, and my italics, it should be utilized more frequently in clinical medicine. It's easy to do because now you have a calculation. Why isn't it used more often? Because mostly it's the blind leading the blind. We're not looking into the scientific literature, and somebody hasn't illuminated the situation so that we can actually see better. Well, here at Metabolic Fitness, that's what we do. We try to help you practice better, smarter, functional and nutritional medicine. If you want to learn more about how we do this or how we can help you, feel free to click on the link below the video.